Welcome to the clinical case outcome from this week. We have a 13-year-old male neutral domestic short-haired cat with 2-week history of abnormal mental status, gait, and posture. The deficits that we observed on the neurological examination were the left-sided head tilt. It was leaning towards the left. It had absent palpebral reflex on the left eye, absent menace response with normal vision on the left eye. And at the time of the presentation, we considered the cat had a normal mental status. However, the owner reported that it may have been a little bit quieter. So when we talk about the neurolocalization, we localize to the left vestibular system and left facial nerve. Talking about the anatomy of the vestibular system, remember that we have the peripheral component and the central component of the vestibular system. What we can say in this particular case is that we have a dysfunction of the vestibular system without obvious signs of central involvement. The involvement of the central vestibular system usually show altered mental status, can have also ipsilateral postural reaction deficits, and if there is the component of the cerebellum affected, then we may see also cerebral signs. So in this cat, as we said, we can say there is a dysfunction of the vestibular system without obvious signs of central component. When we talk about the anatomy of the peripheral vestibular system, your vestibular and cochlear nerve use the internal acoustic meatus to enter the cranial cavity, and the same meatus is used by the facial nerve. So they are two cranial nerves that run very, very, very close. So it's not uncommon to see them affected with the same underlying cause. So when we talk about the facial nerve, it exits through the internal acoustic meatus, and at the level of the petrosal bone, it bifurcates, and the parasympathetic component will go rostrally, while the motor function and sensory will run around the bulla, and it exits through the stylomastoid foramen. Also remember that we have the postganglionic axon, the one that contributes to the sympathetic innervation to the eye, that also run very close to the middle ear. Middle and caudal to the bulla, we have the cranial cervical ganglion, and your postganglionic axon will go through very close to the middle ear. So we have a lesion at that level. Is not uncommon to see cats or dogs affected with vestibular signs, dysfunction of the sympathetic innervation to the eye, so a degree of Horner syndrome, and a dysfunction of the facial nerve. Clinically, what we saw in this cat, it was also the absent palpebral reflex. When we talk about the pathway of the palpebral reflex, we elicit that reflex with touching the medial canthus and the lateral canthus. Remember that the medial canthus, the sensory, is by the ophthalmic branch of the trigeminal. The lateral canthus is by the maxillary branch of the trigeminal. They enter the cranial cavity, they join the trigeminal ganglion, and then at the level of the pons, you have some interneurons where we activate your facial nucleus. We will exit through the internal acoustic meatus, surround the bulla, exit through the stylomastoid foramen, and make the constriction of the orbicularis oculi. So in this cat, we know it was the facial, because if you remember the facial sensations, or all the trigeminal nerve was working fine. So then we can say that the absent palpebral reflex was due to the facial nerve. Remember that the facial nerve has motor component to the muscles of facial expression, the caudal belly of the digastric muscle and the trapezius muscle, is parasympathetic to some of the salivary glands and the nasal and lacrimal glands, and sensory to the two-third rostral of the tongue and the inner part of the pinna. So this is just an example. When we talk about the digastricus muscle, it has two bellies, the rostral and the caudal, and then with facial neuropathy, we can see some degree of atrophy of the caudal part of the digastricus muscle. So that can be, as Fraser explained on the description of the MRI, you can see a degree of atrophy on the caudal digastricus muscle in this case. So putting everything together, we have the 13-year-old male neutral domestic short hair with chronic progressive lateralized, non-painful left vestibular system with no signs of central component and left facial nerve. So based on the differentials on MRI, we had this bilateral otitis media, the left sided otitis interna with a degree of focal meningitis, and there was abnormal contrast enhancement of the left facial nerve and vestibulocochlear nerve with changes of denervation in the caudal part of the digastricus muscle. So I would suggest you if you haven't done it, listen at this description of the MRI in this case, because it's very, very good from Fraser. So the outcome of this case, the cat underwent left ventral bulla osteotomy, where purulent material from the bulla was swapped for bacterial culture and histology. The histology of the tissue sample was consistent with inflammation, and it did not show any aerobic or anaerobic organism at 48 hours of culture. But we, based on the MRI images and the involvement of the meninges, it was started on amoxicillin clavulanic, and then also a course of meloxicam. The cat did improve, and it was discharged after a few days from the surgery. It was suggested regarding the right ear. At that time, we had two options. So we could perform a right ventral bulla osteotomy. On those cases, see how the cat responds to the medical treatment, and see if the cat doesn't develop any clinical signs, he would continue potentially showing or continue medical management. It can respond to this treatment. And there is a recent paper where he evaluated clinical features and short-term outcome with the presumptive intracranial complication associated with otitis media and interna. And it's important to remember that cats with otitis media and interna can definitely have some intracranial component, even if you have an otoscopic examination that is normal. And the antibiotic selection should be based on the culture and sensitivity. And initial antibiotic therapy should be included with both spectrum coverage, with special consideration of the Pasteurella multocida. And interestingly, good outcome with either surgical or medical management. And in this case, we treated surgically the left ear, but we decided to treat medically the right ear because did not show any severe signs. And the cat at the moment is doing well, so it's still a question mark on those cases, how well the medical management can fully resolve those lesions. And ideally, it will be very interesting to do a follow-up imaging on those cases. If you have any question, please let us know. Otherwise, I hope you enjoy the case of this week. Thank you.